Hello, everybody. My name is Garrett Schmidt. I am the managing editor for ACOExhibitHall.com, and I'd like to welcome you to today's webinar. It's been hosted by Salient Healthcare and Mingle Health, titled, "So Now that Quality Reporting is Done, How do we make it easier next year?" So this is a really important topic and something that I think you will all find very valuable. So I'm definitely excited to hear these guys present today. A few items of note before we get started. Everyone, all the attendees, including yourself, have joined the webinar today in listen-only mode, so you don't need to worry about muting your microphone. That's been done for you. And also note that the webinar is being recorded, so you'll have the opportunity, and we hope that you do, rewatch it after the session, share it with colleagues, etc. And what I'll do is I will send a link to the recording to all the registrants after the presentation. So I will send you that email afterwards. And you'll also be able to access the slides there as well. And finally, today we want to hear from you. So please submit your questions. You should have a little attendee control panel where there's a question module that you'll be able to submit questions there. So please do that, and we would love to hear from you. Now, you don't have to wait till the Q&A session to do that. You can submit those questions at any time. So please do that. And if we're unable to get to your question in the allotted time today, then we're going to make sure to follow up via email afterwards. So please, again, ask your question if you got one. At this time, I'm going to turn it over to Miss Amy Kotch, who is with Salient Healthcare, and she will do the introductions and get us started. So welcome, Amy.
Thank you, Garrett. All right, good afternoon, everyone, and welcome to Salient and Mingle's webinar entitled, "So Now That Quality Reporting is Done, How do we make it easier next year?" This is a hot topic, and this change in quality metric submission is rather disruptive. With that in mind, Salient partnered with Mingle Health to put together a talk to hopefully ease your initial shock and ensure that we as experts in this arena are able to help you out. So please ask those questions, we'll field them and hopefully get to answering them all. Now, let's talk about who's speaking today. The experts speaking are Jeff Iasilli, he's the VP of Operations and Major Accounts from Mingle Health. We also have Alysen Casaccio, the VP of Client Services for Mingle Health, as well as Maria Nikol, the Senior Business Consultant at Salient Healthcare, and then myself, Amy Kotch from Salient Healthcare, and I'm the Principal Business Consultant. Now, speaking from a personal standpoint, I can tell you that you're in good hands when it comes to quality metric expertise, because Jeff has been working in healthcare IT for the past 25 years, leading service and product teams at vendors like GE, IDX, and Allscripts. And when it comes to process improvement, he is a Lean Six Sigma black belt, which enables him to apply learned tools and techniques to help improve and maximize quality. As for Alysen, well, she brings a unique perspective, being that she's both clinical and technical. She's a board-certified nurse in informatics and has experience with several EHRs, including multiple Epic certifications. And like Jeff, she's familiar with the process improvement cycle with her training in change acceleration processes and executive coaching. Now that brings me to Maria. She brings an excellent policy perspective, being that she has been in the VBP space for the larger part of the past 11 years, working diligently to improve healthcare operations and strategy across emerging models of healthcare delivery. Then that brings us to myself. I have over 6 years of ACO and MSO experience focusing on continuous process improvement, aligning industry needs with the shift towards value-based care models. Both the Mingle and Salient healthcare teams bring enough expertise to help you learn about how to make your quality metrics submission and reporting a whole lot better. We're here to help you navigate through this disruption in quality performance. So with that, let's talk about today's agenda. We're going to provide quality reporting overview. We're breaking it down with a timeline of events and sentinel changes, followed by a review of how reporting was completed prior to 2021. We want to get everyone on the same page so that we can move into the new world of quality reporting that is aligned across MIPS and APM programs through the APP, so that we know how to submit quality metrics for the future. Alignment has been CMS's agenda, as well as data integration and transparency. So we really are starting to feel that right now across the industry with the changes for 2021 and beyond. So I'm going to hand this over to Maria, who's going to give you the overview of quality reporting.
All right, so before we dive into the how of quality reporting, I wanted to take a quick step back to look at the evolution of quality measurement processes. In October of 2007, the Institute for Healthcare Improvement, or IHI, launched the Triple Aim initiative designed to improve the patient experience of care, including quality and satisfaction, improve the health of populations, and reduce the per capita costs of healthcare. This became the foundation of value-based care. VBP organizations strive to provide the right care at the right time to achieve the best possible outcomes. Those outcomes are measured by quality metrics, and organizations need to report on quality metrics through the quality metric submission process. So 1 year prior to the creation of the Triple Aim, Elliot Fisher came out with the term accountable care organization. ACOs are an exemplary VBP arrangement, which use a fee-for-service as the foundation. Participating ACOs must report quality data to CMS at the close of every performance year to be eligible in and earn any shared savings and avoid any shared losses at the maximum levels. CMS measures every ACO's quality performance using those standard methods. Now, quality measures span across 4 domains: patient and caregiver experience, care coordination and patient safety, preventative health, and at-risk populations. So as many of you are already aware, there are challenges associated with the reporting of quality metrics. First, quality metrics evolve and change over time. And in fact, the measure specifications are updated annually, and each year there are changes to the numerator, the denominator, exclusion codes for every metrics also change. Now, you also have quality metrics that might vary across all of your different payer contracts, all of which need to be reported annually. There's also an increase in complexity, whether you're a primary care or a specialty-driven organization. Second, there's also a variety of data sources from which quality metrics are compiled from. You have the CAHPS, Patient Satisfaction Survey, claims-based quality metrics, and EHR metrics. Of course, this complexity also increases if ACOs have multiple EHRs. What most organizations don't consider is that even if you have the same type of EHR, each practice actually might be on a different instance of the EHR, which adds to the complexity of pulling and aggregating that data for quality reporting and submission. Now, it said that quality metrics change over time, but additionally, quality metric reporting requirements also change over time. Over the years, CMS has made significant updates and changes to the quality metric reporting program. Looks like about every 5 years, there's a significant revamp to the quality metric reporting requirements. With the inception of the MSSP program in 2012, quality metric reporting was a pay-for-reporting process for 33 quality metrics in the first year of the program. For the subsequent year, more and more metric changes were changed from pay for reporting to pay for performance, meaning that organizations needed to meet a quality threshold for each one of the measures, not just simply report on it. In 2016, as many of you probably remember, there was a lot of changes that took place in quality reporting. With the Medicare Access and CHIP Reauthorization Act of 2015, or otherwise lovingly known as MACRA, legislation was signed into law on April of 2015. MACRA was created to create the Quality Payment Program. The intent of the changes was to repeal the sustainable growth rate formula, change the way that Medicare rewarded clinicians for value over volume, and streamline multiple quality reporting programs under the new MIPS, or merit-based incentive payment systems, and give bonuses for payments for participating in the eligible alternate payment models. Now, many of the participants on this call likely made the decision to enter into those APM models as a result of the benefits derived from MACRA. Now, interestingly and completely unrelated to quality, MACRA also required CMS to remove Social Security numbers from all Medicare cards by April of 2019. So, right on cue, about 5 years later, CMS pushed out a pretty significant change to quality reporting. The intent of the program is to continue to push providers towards high quality care for all patients, rather than just checking the boxes at the end of the year. So with that, I'm going to go ahead and hand it over to Jeff to discuss these changes and how your organization will need to prepare for those changes.
Great, thanks, Maria. Evolution, that's how progress happens, right? Before we start looking at changes to the APM Performance Pathway, APP for short, let's do a quick review of the process you've been using. Love it or hate it, as an ACO participating in the Shared Savings Plan, you've been reporting to CMS using the web interface. As you know, the ACO is composed of member groups and a patient population covered by lots of different insurances. Web interface reporting is a one-time event. It's separate from quality measure monitoring you may be doing throughout the year. And CMS provides you a patient list files at the end of the period, that is in January. And then you have 3 months to do the chart abstraction for 10 measures. This method requires the ACO to report performance for only your attributed Medicare beneficiaries, right? Then CMS identifies a random sample of 248 beneficiaries who qualify for each of the 10 measures. Alysen will talk later about the measures. Typically, the patient's chart is evaluated, that is abstracted, to determine if the patient met the measure requirements. The person doing the chart review needs to know how to score that patient visit based on the criteria in the measure specification. Actually, in each of the measure specifications, remember there's 10 there. For example, the web interface measure DM2, diabetes, HbA1c, and poor control, you need to find the most recent A1C lab value for the sampled patient, the diabetic patient, in their chart. And if it's greater than 9%, that patient met the measure. Not good in this case. The score is then recorded in a spreadsheet. So it's a manual process. And as mentioned, CMS doesn't provide that patient list until January. So you only have 90 days to get through this process. Once you've scored all the sample patients, you have to upload the spreadsheet and wait for results. All right, so that's web interface in a nutshell. You know it, you've been through it. It's always an interesting process. So why is CMS moving to APP? The CMS's overall goals are really to improve quality and reduce cost for us quality wonks. That's really the same thing. But they're moving to better align all their different quality programs. One goal is to make better provider comparisons. With all the different programs, it's really hard to compare how providers are doing across the board if you're not using similar measures. So the Medicare Shared Savings Plan, like most APMs, has its own reporting rules, its own measures, its own mechanism, so they simplified it. They're also trying to align the program under the MIPS value pathways, or the MVP. Probably heard of it. They'll be rolling that out over the next couple of years, but the APP is the first part that made it officially into the rule. So let's talk about the new APP reporting process. Under the APP, MIPS rules apply. All qualifying patients for each measure, all payers. That's it. All payers, not just Medicare. That means your denominators, the reported measure populations, will increase and expand. Increased number of patients, but also because we're looking at all payers, your patient population will expand beyond the typical Medicare 65 plus group. So do you know how your 18 to 64-year-old patients will perform for these measures? Unlike the web interface, the APP is not a sampled measure. We're really expected to measure all qualifying patients. A good data plan will be really key to your success in managing your costs. Alysen, let's compare the program details.
Sounds good. So here are some milestones that I think you guys will really care about. For example, in 2020, in that performance year, ACOs received full credit for the patient experience of care. Now this year, 2021, any ACO participant can choose to report either the 10 measures via the web interface route or the 3 measures in the APP. There's this fantastic opportunity here to start looking at your all patient, all payer data and really engage in the conversation about how you can make this work in 2022. The most proactive ACOs will be using this time to review and understand not only the 3 measures, but the ECQMs versus the MIPS CQMs or the registry versions and how they differ. Review the results you're currently getting side by side through the 2021 year and be prepared. At the end of 2021, if you still want to do a web interface submission for that year, great. But now you have the information you need to actually improve what needs improved in order to get the best scores possible for 2022. Now, if we move to the next milestone, starting in 2022, the APP is required. This means year-round monitoring and improvement with a submission to the APP at the end in 3 key measures. Your ACO will need to decide which is the better, most feasible option, ECQMs out of a certified EHR or registry CQMs. We'll talk about these 3 measures in a moment. In addition, in 2022, ACOs will be required to field the CAPS for MIPS survey, and CMS is going to calculate 2 measures using administrative claims data. So this means your total submission will have 6 measures. If you haven't previously worked with a survey vendor on CAPS before, that's another reason to get started with a registry in 2021. So you're confident your organization is going to have the time and resources needed to devote to your survey project and that your quality measures are really well in hand. And then again, 2023, the ACOs have a performance threshold of the 40th percentile. So monitoring and improving the quality of care at multiple organizations really requires a multi-year investment of effort and a good long-term strategy. So those who start planning now will simply have better results by the time the requirements make achieving incentives more difficult. You don't want to be trying to take your first measurements of this information in December of 2022. The fact is, delaying is just not going to lead to success. Let's take a look at some of the measures themselves and the challenges that we can help you with. So you can see here the total list of measures that used to be the focus for web interface submissions. We've got CAP surveys, 2 claims-based measures, and previously 10 quality measures. CMS has, on one hand, streamlined this quite a bit. You'll now only be responsible for CAPS, claims measures, and 3 quality measures: A1C, poor control, depression screening, and control of high blood pressure. On the other hand, because we're moving from Medicare sampling to all patients, all payers, like Jeff has said, we're going to be looking at more eligible instances to evaluate. Instead of 248 patients per measures, it is likely to be thousands. I want to go through some of the different ways to examine these 3 measures so you can begin to think about what kinds of challenges they may present for your specific organization and consider ways to plan proactively about them. While we're here, let's think a moment about the population that hasn't been eligible for web interface measures previously. The hemoglobin A1C measure that checks to make sure that A1C tests are performed and that those results are less than 9 that Jeff talked about, these 18 to 64-year-olds with diabetes are new to our measurement when we move away from web interface. And the clinical approach to an 18-year-old diabetic must be different than the approach used for a 70-year-old. Sorry, Amy, I'm still on that previous slide. I'll wrap up though. So if you treat an 18-year-old like a 70-year-old just because they have diabetes, you're going to see some rebellious life choices, and that isn't going to lead to good outcomes at all. So we can't assume just because we've performed well in that sampling system that our clinicians are also doing well across the entire population. We have to measure it to know, which brings me to the slide that Amy's showing you. Let's talk about performance. The example here is of the blood pressure control measure. Sorry, Amy, if you could go back one. Often when organizations talk about these measures, we talk about them from the perspective of the title only. Depending on the measure you choose, however, there are subtle differences. CMS publishes their national average performance against each. And this is a bit of a lagging indicator because they typically take a 2-year cycle for CMS to analyze those national results. So you can see here in this slide, our average performance is what we've seen in just those organizations who are clients of Mingle Health. But it's a bit more recent because we're just looking at the past year. So anecdotally, if you've been using web interface, you may be expecting somewhere between 50 to 75% performance rates on this measure. You can see that both the registry and the EHR versions run a little lower, and we found that the registry version tends to see higher performance rates, which is reflected in the benchmarks. One other thing to mention about this measure is that it's designed to tell us how effective our clinical interventions are with these patients. So for this one, we are looking at only patients who've already been diagnosed with hypertension. When looking for patients to approve for the numerator, the first check our analytic software does is look to see if the eligible patient's most recent blood pressure reading is adequately controlled or under 140/90. Now, the registry measure gives some amount of flexibility or benefit of the doubt here. We don't have to count blood pressure readings taken in the ED, for example. Patient will probably be a little anxious there. Maybe their blood pressure will be higher. Or if the patient had a test that day that required them to hold their medication. Our software is allowed to use the lowest reading if you have multiple blood pressure readings in a given day. So in this way, we can capture the greatest number of patients for the numerator possible. It also means that improving performance rates for this one means we must have blood pressure readings to analyze. If there's no blood pressure reading in the data at all for that patient for the entire year, we have to assume the patient's blood pressure is out of control. And fair enough. We know blood pressure is something that the eligible clinician rarely does themselves in the ambulatory clinic. It's the rooming nurse or the MA that's going to be taking and entering that reading. But it is important for the clinician to review what's been documented, take the appropriate interventions, whether that's retaking and documenting it, we use the lowest, right? Or making adjustments to a medication regimen and having the patient return to check and see that that adjustment's working. Sometimes, though, lower performance is not a direct line to a poor quality of care that's being delivered. And I'll show you that in the next slide on depression screening and follow-up. So when clients ask why the ECQM or the EHR version benchmarks are lower or why registry measures perform higher, one of the primary culprits driving this difference is documentation. So in this measure, depression screening and follow-up, we know the patient needs screened for depression. But if you get a positive screening, our next step is to examine how the follow-up action is documented. The examples I have here are just common ways we see this clinical data come in. So if that PCP orders a psych referral and fingers crossed there are no complications in the EHR's referral flow from one practice to another, your patient will fall into the numerator on the ECQM report and all is well. Same goes for the medication order. All the follow-up actions, if documented appropriately, will be mapped behind the scenes to things that the computer can read, like RX norm codes, SNOMED CT codes, and other structured records. The examples that tend to fall through the cracks in that ECQM report, however, are things like these bottom 3 examples here. So let's say the doctor talks with the patient and he's been seeing a therapist for the past 10 years, out of network, not referred to anyone by our practices. Or maybe we just have some challenges in that referral workflow. The doctor may not know how to enter a new provider into the system, doesn't have time, or it's just not coming up in the search that's provided. So what does that clinician do? It goes in their note. And the same for these other examples. So clinicians don't always follow the workflows as prescribed by their EMRs, and sometimes there's legitimate reasons for that. It doesn't mean the quality of care isn't being addressed. It just means it's not being documented in a way that the EHR reporting logic can see it. And it's essential for you to understand why performance may be lagging. Because if you attempt to fix the wrong problem, it's just going to lead to wasted effort and, frankly, frustrated clinicians. So in web interface, we caught these details in our chart review, because there were live humans reviewing the cases. Live people can make clinical judgment calls about the data where computers can't. The registry process also involves live people. We have a team of clinical informaticists who understand and assign value to records that are otherwise overlooked, using some internal tools that Mingle's built to pull needles from haystacks. Registries are allowed the flexibility to do this, so we can take advantage of all your data, not just the data points that fall into that narrow workflow. Now, if all of your clinicians are not following that prescribed workflow every time, those ECQMs may not be reflecting your best clinical performance. This is where 2021 is really an opportunity to use this side-by-side comparison to really highlight which clinicians are following the EHR workflows, which aren't. And if your goal is to get everyone on the EHR workflow, again, seeing those measurements is the first step toward an intervention. Then we can decide, measure by measure, which version gets you the best score as you work toward improvement. Because again, what often matters to our stakeholders is results. So Jeff's going to talk to us a little bit about how this actually works and how we get the data to do all of this in the first place.
Great insights, Alysen. Thank you. It's a lot to think about. It's a big change, but you can do it. And here is what you need to do to prepare to succeed. All right, the challenges APP presents are very much like those Mingle was built to solve. Since PQRS days, we've served the healthcare community from single doc practices to large academic health systems. We've developed flexible technology that we can use, and we can use a variety of data from multiple sources to calculate performance and provide ongoing monitoring. This gives you the opportunity to improve performance while there's still time, and we send the results to CMS on your behalf, monitoring and submitting all with the same data and all with the same system. If your ACO has an enterprise EHR that all member groups and participating providers are using, you may have the option to report either registry or the equivalent ECQMs. This is a frequently asked question I get from the ACOs I've been talking to, and I've been talking to a lot of them lately. If you plan to use ECQMs for APP reporting, and many of them are, they need to be calculated and reported in a single report. If you have multiple EHRs, which many ACOs do, you can't just add up the results from each system. That single report for submission has to be produced by an ONC certified EHR. Okay, so for a lot of reasons we've already mentioned, registry reporting is a more flexible option. I've actually seen recently some companies say that it's either ECQMs or a manual process. Not true. Mingle developed processes and tools to aggregate data from multiple systems to calculate measure results that are true, accurate, and complete. That's why we're a CMS qualified registry. And we can also provide the visibility you need to validate your data down to the patient visit to be sure your data reflects your best performance, like Alysen was just talking about. So here are recommendations for preparing your organization for success. Get a data plan. APP is all payer. CMS won't be providing patient lists under APP. Your existing billing files may be a great source of this data that you're already producing. Are you on one EHR or on multiple systems? ECQMs may not be a practical option for you. Alysen already talked about CAPS, but CMS waived the CAPS patient survey for ACOs in 2020. If you haven't done so yet, you need to select a vendor. Surveys are required for 2021 and beyond. And we've been talking a lot about measurement. Measurement and early action is key to improvement, avoiding unpleasant surprises when it's time for submission. Amy, can you show some of the solutions that we can provide to help our ACOs succeed?
Absolutely. Thanks, Jeff. So we're going to do a little demo here, and I'll pass the ball over to Jeff in a second, but there's two things you need to consider. There's the year-round actionable reports. You need to ensure that you have something that's telling you how your doctors are performing. So what I'm showing you is a screenshot of our dashboards that are coming soon, And what you'll see is you're filling up each of these images as you complete the measures. You need to ensure you have the right denominators and numerators that fulfill each of these and know what the exclusion criteria is and have a way to view it. And you'll probably want to take a look at this information on a regular basis, maybe monthly as claims roll in. And that way, you can start fixing areas that might need further improvement. You'll also want to be able to drill down to the individual practice and provider levels. That's where you're going to really see where you need some assistance. So having year-round reporting that's going to help you identify areas of opportunity is what you're going to need so that you can do your year-end submission. So I'm going to pass the ball over to Jess, who's going to show you what their system looks like live. All right. Jeff, I made you the presenter.
All right, let me see if I can make this work here. Working, all right. Yay, that was easy. Okay, all right, so Mingle, as I mentioned earlier, has been helping groups monitor and report quality data since 2012. We've built a technology-enabled service that gets rave reviews from our customers. We use all payer claims data to identify the tax IDs, that is the practices, and the NPIs, the providers, so there's no cumbersome data entry. Let me just get us into our quality module and I can show you around a little bit. Here's an example of some of the files that are uploaded. And let's go into our quality module. Thinking, and here we are. All right, so in the APM solution, you will be able to track ACO performance, measure practice, and individual provider results. All right. Let me go back here. So we start with the denominator data. As we mentioned, that's the population that is eligible for the specific measure that we're talking about. Our measure algorithms determine and calculate the qualifying patients for the visits. Those are displayed here in our patient visits, right? Next, we apply the numerator data from the clinical data out of your EHR. We calculate performance, so those denominator visits are matched to the numerators. There's no manual process here. We use the data and our expertise to score the performance automatically. You see that here in the performance rate. Scoring for the APP is based on the performance rate and tied to the measure benchmark percentile, as Alysen had mentioned earlier. Just a quick note on the reporting rate. Here's our reporting rate here. The reporting rate is really the percentage of scores we can determine over the number in the denominator. So the MIPS rules require that be at least a 70% data completeness rate. This is a concession that CMS, a rare concession, I should say, that the CMS makes to the real world, where they know that all the data may not be available. But CMS is very adamant that this isn't used to actually improve your performance. It's really just, again, that concession to recognize, all right, sometimes all the data isn't available. All right, so here you can see the results for also the individual groups that are making up the practice. And the individual providers within those groups. You can even go from here all the way down to the individual, again, the individual performance, and then drill down all the way down to the patient level and the actual visits that we're evaluating that make up that data. And then submission to CMS is really, really easy. Once you've approved the results at the practice level or at the provider level, you can actually just go ahead and review your submissions and send them off with a click of the button, and Mingle takes care of the rest for you. Amy, can you take us back to the slides so we could talk a little bit more about how to make reporting decisions?
Sure, you've got to hand me the ball.
Oh yeah, there's that part, isn't there? Amy, where are you? Here you are. Yes, I'm sure.
All right.
There we go. All right. So analytics are really key to the success and ROI. As you know, there is a lot at stake. Are you measuring what matters for both compliance and improvement? Can you use your data and analytics to focus your valuable resources on what the most improvements are, identify your gaps early, and use the data and create plans to close them? Who needs to know and support improvement where it's needed? This is a challenge at any practice at the practice level. Alignment, strong communication, and measurement is critical to moving your ACO forward. Under all this is data and knowing where it's coming from. And to ensure it's complete and indicative of your performance, you need a plan. Actually, I think Alysen has a plan.
Thanks, Jeff. So yeah, one of the big things that sets Mingle Health apart from other registries you could select is our consultant team. You'll have a dedicated expert consultant assigned to you. Their focus is going to always be on your goal setting, your unique challenges, and ultimately your success. We use a standardized project plan with clear target dates throughout the year that really helps our clients succeed. We simply walk each organization through the steps of what they need to do in order to be proactive and achieve the goals that they set at kickoff. The consultant also brings a national perspective to your table. They can tell you how other similar organizations have handled the problem or problems you're facing in the moment. And because they're assigned to you, they're available for questions, subject matter expertise, and some of our clients even use them as a digital colleague in their pocket if they just need to bounce improvement thoughts and ideas off someone. Notice in the third row of this slide, there are these blue arrows. So adding data and monitoring performance is really an iterative process. This is also where your organization might implement some interventions, whether that's clinician education or documentation and workflow standard changes. As you improve, that gets reflected in the data, and then the data becomes improved performance. This is true ongoing monitoring. Our analytics will be showing you if your efforts are effective sooner, so you can get recommendations from your consultant and shift directions faster. Basically, you can be more agile. So I'm going to turn it back over to Amy to talk more about our joint approach.
Yeah, thanks, Alysen. So let's talk more about that consultative approach. We just talked about, the history of quality metric submission. We've shown you the metrics, what needs to get done in terms of year-round performance tracking and how to submit. But then it's how do we actually do better? What do we need to do to move the needle? And this is where the consultative approach comes into play. So coming from experience, we know that the annual wellness visit is an excellent way to capture the majority of preventative measures, as well as identify gaps in care while building a strong patient-physician relationship. Annual wellness visits must be a main initiative to ensure proper quality metric compliance. Once the gaps have been identified, you'll want to look at the aggregate level to see where targeted initiatives should take place. For example, if your providers are low on the flu shot metric, then you might want to partner up with, say, a Walgreens, CVS, and promote getting those vaccines during the flu season. And seasonality is key to many of those preventative quality metrics. For example, mammograms, as an example, I've worked with a group and they actually used the month of October, which is Breast Cancer Awareness Month, and essentially did a big push for mammography. And they had a bunch of nail technicians and hairdressers and masseuses come to the women's health facility, and that helped increase their mammography capture rate, twofold. So they really use seasonality to their advantage. Another thought is maybe you have a gap in office efficiency. So maybe your primary care docs don't have the time or resources to do fall risk screenings. So you may want to consider partnering up with PT and OT in the area or in your ACO, or even ophthalmologists for diabetic retinal exams. Many practitioners are already outsourcing a lot of their mental health work, so why not ensure that your PHQ-9 is being captured by a partner provider? So We've also thought of ways to do this via telehealth. You know, Pandora's box has been open now with COVID, and maybe we can start capturing a lot of those quality metrics telephonically, or even just nudge patients in the direction towards getting those captured. So you have to really start thinking outside the box. There's a bullet on here that also talks about EHRs, and I want to point out that you need to ensure your providers are capturing the information and putting it in the same place across your EMRs. Alysen pointed this out before, but that phrase, you know, garbage in, garbage out, really does hold true. You need to make sure that all the effort you're putting into integration and making sure you're actually doing the care and work that's needed is being read by your EMR so that it's being fed into the system and you're not being penalized for work you're actually doing. Data entry is key. So whatever the case is, identify your areas that need improvement and recognize that you're going to have to do something different to make a change. We're all taking steps towards value-based care, and this is just part of that journey. So with that, I'm going to thank everybody for attending, and we will be answering some questions. So thank you.
All right. Well, thank you guys so much. This has been a wonderful presentation so far, and we did have a number of questions come in. So without further ado, we will jump into these. Some of these may be directed at individuals, but I think for the most part, they're kind of general. So you can just chime in as needed there. The first question, and these are in no particular order, is someone says, "Hi, Amy and Maria." And then we also have, okay, the verbiage is specifically addressing ACO. Can you confirm it is the same for anyone in MIPS?
I think, Jeff, I'm going to go ahead and just, one of the things that I would probably mention is that this is absolutely for anyone who is currently using web interface. So yes, our verbiage definitely has been directed at ACOs, but if you're in any APM that's using web interface or just a large organization who's been using web interface, this is really, web interface is going away.
Yeah, that's a key point. There are some groups that are using web interface that are not part of the shared savings plan, and they're using web interface because of the sampling method and for a number of various reasons. Those groups will not be switching to the APP. They will have to be going straight to the standard MIPS process. One of the things that we also didn't mention is that the groups that compose the ACO can also submit MIPS. They can do that as well as the APP, and for incentives, the best scores and the highest incentives will be applied. That doesn't absolve the ACO from reporting. Obviously, the ACO and as participating as part of the shared savings plan, you're required to report for that group. But the individual groups can also report as MIPS.
It can be a way for ACOs to keep their member practices and member NPIs happy, especially given that according to the benchmarks, the web interface measures perform so high. And so you are likely to see a drop if you have particular TINs or particular NPIs that you think are going to push back on that. Doing a traditional MIP submission in conjunction with the APP is a fantastic way to do that. We can help you figure out across your entire member population where's the biggest bang for your buck there.
And more importantly, you have to do it this year because we're transitioning really quickly. So you got to think this is the time to make those decisions and figure out which practices need that help.
Yeah. Absolutely. Yeah, there's a certain amount of planning you need to be able to make an educated decision. So even if you choose and actually most of the groups I'm talking to are actually considering reporting under the web interface for the last year. And I want to make that clear. This is the last year that you can do this. You can report by either method in 2021, but 2021 will be the last year that web interface is available to you.
And even if you report web interface at the end of this year, I think it's a good idea to start looking at the APP measures, compare them side by side, know what's coming.
Very good. Cool. All right, next question is, Hi, Jeff. What solutions do you offer for some of those practices that are still on paper?
Paper. That's a really good question. Part of, as I've mentioned before, sometimes paper makes things virtually impossible. That's where that 70% completion rate comes in, data completeness rate comes in. I had mentioned we have a number of different ways of collecting data, and we try whenever we can to use the data that is already produced by your healthcare IT systems, whether it's your practice management system or your EHR, typically a combination of both. We can also support a manual process. You may be able to provide claims so we can identify your patient populations. I showed you that detailed patient list before. We can actually download that patient list for you after we've identified the patients that qualify for the measures and allow you to, very similar to what you're doing in web interface, to basically manually score those patients. Obviously, in most cases, you're going to have a lot more patients that you'll have to score, but particularly for groups that are on paper, those are usually smaller practices, smaller patient populations, and we can deal with that both at the practice level and for the ACO through a variety of different ways of collecting data, even all the way down to a manual process if necessary.
Great, and we had several questions come in regarding that, so that one should cover that. Next is how does telehealth and RPM collected data play into all of this?
I can speak a little bit to
You
telehealth.
want to take that, Alysen, or I could take it. I mean, really, when it comes down to it, the way the care is delivered, as long as it's documented in the system, which it would need to be reported, it's not really relevant in terms of whether it was a telehealth visit or whether it was an in-office visit.
And maybe what that, oh, sorry.
No, go ahead, Alysen.
I was going to say maybe what that question is referencing is the fact that because telehealth really exploded through the time of COVID, we have these measures that do get revised every year, like Amy mentioned. And previously there were MIPS measures that many of them simply excluded a patient from the denominator if they were in telehealth. As of this year, that's no longer the case. There are quite a few measures that very explicitly say, nope, if you're telehealth, you're still in the denominator. And so it's a really good idea to have a good understanding of where those telehealth patients are and what that quality of care is like. Did we deliver the same high quality care via telehealth as we did as somebody who's sitting face to face with us in the office?
Yeah, and if you're using telehealth as a means of having another touch point with the patient, if it's DCM purposes or you're just visiting with the patient, it's a good time to put in that extra reminder. Hey, you're missing this. Just having someone reiterate that point of this quality measure is not being met and having the doctor, come from your provider is going to reinforce that.
And I think this is one of the key values I want to call out here, both for Salient and for Mingle, is that you're not just buying technology, you're buying expertise. So the folks that you're working with, your dedicated consultants, all are program experts. They've seen this dozens or hundreds of times. These questions are questions that we hear all the time, and we base our program expertise. We do a lot of education working off of the final rule and understanding the requirements. That's part of the expertise. It's a technology-enabled service, service delivered by real, well-trained human beings.
Cool. All right, next question. We'll keep moving along. We've got a lot. They keep coming in, so this is great. Does the data have to be collected via EHR CQM or a registry CQM? I'm sorry if some of these are repetitive.
Sure.
Okay, you want to take that, Jeff?
Yeah, I'll be happy to take that. Yeah, it's either or, and we can mix and match as well. So really, and this is part of what we would work with you on, is collecting the data, evaluating it, and figuring out what your best options are. Alysen and I both talked about the potential challenges with ECQMs. and that to a certain degree, there's a little bit of black box there around how that data gets there and is driven by standard workflows. We have tools and process that that can expose the registry details in such a way that you can fix them or identify documentation process issues. But yeah, as far as for the APP, you can report either ECQMs, the registry measures, or a combination of them.
And Jeff, can you elaborate? Oh, sorry, I was just going to say, a lot of ACOs probably on the call vary in how many EHRs they have.
Right.
You know, some of them might be hospital-based with just, you know, they're an Epic House or a Cerner House versus some of the independent docs who have, you know, 25 EMRs. What would you recommend there?
That's a really, really good question. I'd say it's more the exception than the rule that an ACO is operating out of a single EHR. I talked to one group a few weeks ago that actually has 36 different EHRs and almost twice as many revenue cycle management systems involved there. From an ECQM perspective, as I mentioned, the ECQMs need to be reported in a single, what's called a QRDA3 summary report. So for the ACO, they need to submit through either a QRDA3 or the data that is produced from a QRDA3 through the API. So you can do that, but the issue really is that's a single report and it has to be generated out of a certified EHR technology. So if you've got 30 different EHRs, where is the one report? There isn't one. And you can't take those individual summary reports and add them up because the measures are not calculated accurately that way.
The other important thing to note here is if you have a single EHR but different instances of that single EHR, they also cannot be mashed up together in a single report.
Right, and that's the advantage from a registry perspective of we've been doing this for years. This is a frequent challenge that is presented by our Mingle clientele, and we can easily aggregate that data, and we're not constrained by the certification process. And as Alysen had mentioned, we can be much more flexible about your workflow and where those data points actually land in your system.
Okay, this is funny. We literally just had a question came in that says, how do you integrate with 30 practices that all have different EMRs? So I think you just covered that.
Yeah, we do that. We do that every day. I mean, it's I think a little bit of maybe I shouldn't speak for Jeff, but I was a little bit surprised at the number of ACOs we've talked to who've said that feels impossible, because we literally just this is how we do MIPS. Often we will have partners who come to us, for example, like a billing company who has multiple practices all on different EHRs, and they want to be able to aggregate that data and see what it looks like at the highest level.
That's a good reason why folks are a little bit concerned about stepping away from web interface, because it's only 248 patients, and yeah, maybe you have to drive to a different practice and look at their chart, but it's not that big of a deal. So there's really no integration there because there's no technology really. You've got a human that's actually doing all of the interfacing, so to speak.
Great. Moving right along here. And we'll be able to take just a couple more, and unfortunately we got to wrap up. But don't worry, keep submitting your questions. We'll get to all of these, if not right now, then by email. So this is great. Yeah, definitely send in your questions. Next question here is, while being a part of an ACO, we would have to report on at least 80% of the population. What does that mean? Or does that mean we could have some of our practice report traditional MIPS while most reported via APP? Does that make sense? You want me to read that question again?
Yeah.
It sounds like you're talking about an 80% threshold for data completeness, right, Jeff?
That's what it sounds like to me.
What we found.
No, you go.
What we found with data completeness in the MIPS program, for example, and maybe Amy and Maria can speak specifically to that 80%, but what we found in the MIPS program over data completeness is that what CMS is actually asking for is 100% of the denominator, which comes from claims. So that's fairly easy to capture. And then we prove through our analytics that, yep, our reporting rate is 80% or 70% or whatever the threshold is to meet data completeness. But a place where clients get confused a lot is they hear the percentage and think, oh, I only have to give you 80% of all of my data. But in order to know what 80% is, we have to have 100% of the denominator to make that calculation. But then we'll make it and we'll display it easily for you.
Right. In the MIPS rules, the expectation is that you're reporting off of your entire patient population.
Yeah, and this goes with the whole concept of CMS doesn't want you cherry picking. You know, they want to see everybody. They want to make sure that it's being done across all populations.
The reason these thresholds are in place, like Jeff mentioned before, is it's a concession on the part of CMS to say, okay, so you don't have access to one system out of your 35. Okay, well, we'll give you this percentage of wiggle room. That percentage of wiggle room applies to the numerator data.
Very good. Okay, last question that we have time for, unfortunately, and again, there are more, but like I said, we will get to you via email afterwards. This question is, what is different to the results you are dashboarding compared to what they get out of the current EHR reporting, say Epic dashboard? Do you have any ops issues with the methodology of the calc is different, if the calculation is different?
So the differences between the registry version of a measure and the EMR version of a measure, they actually have different specifications. So one way that I explain this is, let's say you're using the Epic system. What Epic is going to do at the beginning is they're going to say, here's your patient population, which is all patients in Epic. And then they're going to say, okay, so here's all your patients. How many of them have diabetes? And that's how they narrow it down, right? On the registry side of things, what we do is we say, okay, how many patients in the last year had a CPT code of an office visit? And we've got groupers that CMS provides inside our spec sheets that give us what those numbers are. And of those, how many of those had an ICD-10 code for diabetes? Again, big grouper, right? And so that's how we establish our initial patient population. And then from there, it is a narrowing. On the EHR side of things, it is, did you click this button in this workflow? And on our side, we pull the clinical data and the specific data points that each organization, where do you document this? Where did you document your A1Cs? Great, give us those results and we'll cross-reference it for you.
Right. The challenge, I think, too, is, as I mentioned, we can show you the individual patients and you can look at those patients and say, wait a second, I know this patient met it. And like to Alyson's point, well, they did meet it. The doctor wrote it in the chart instead of put it in the standard field. So we can actually pull that data and say, yep, that one's met. Or worst case scenario, you can amend that data through that manual process that I mentioned before. Mm-hmm. In the EHR measures, it's much, much more difficult to say who are these patients and what is the reason that they were included or not included.
Very good. Very good. Well, unfortunately, guys, that's all the time we have. I know this is a really hot topic. There's a lot to discuss here. Again, if you have a question, please submit it as we're wrapping up here, and we'll get back to you. Thank you all. Thank you guys so much for the presentation. It was very informative, and really appreciate everything you had to say. As we conclude, I wanted to encourage you all to visit the ACOexhibithall.com and see the Salient Healthcare booth that they have over there. It's interactive. You can get a chance to interact with their team, see what they're doing. It's a really cool venue that you can play around with. And also, I wanted to let you know that on the ACO Exhibit Hall, in the reference library is where the recording will be housed. So if you don't, for whatever reason, receive the email in a couple days, check in the library there. It'll be via reference, probably within the next 24 hours. Thank you all so much for attending. I hope you found today's presentation very informative, very helpful, as I did, and have a great rest of your day. Stay safe and stay healthy. Thank you.